No? So what happens is, let me try to summarize about, see, nuclear medicine is a emerging branch which is finding more and more application, not in different forms of medicine, for example, like the cancer, sports physiology, and the other parts of medicine, but even in cardiology as well, its application is becoming more and more wider. It has been since a long time, I would say in 1920s, one of the first times. So what was happened is one of the drugs like radon was injected by Hermann Blumgart, 1927, when he tried to measure the circulation time. And later on, similarly, another scientist by name Liljestrand in 1939 tried to measure the blood volume, in fact. And I'm sure everyone can remember about Prinzmetal, okay? Miron Prinzmetal in 1948, when India got its independence. During that time itself, he used radio-labeled albumin. And one of the major big breakthrough for nuclear medicine or nuclear cardiology was in 1952, when the gamma camera was being starting to use by Hal Anger, in fact. And especially in the 1980s, there was thallium-201 two-dimensional planar imaging, which literally revolutionized. And especially since then, there has been a huge usage of the various tools and technologies for the usage of nuclear medicine, especially things like the rotating Anger camera, or even since the 1990s, one of the agents like technetium-99m, which is being used for the gated SPECT as well. In fact, 90%, I would say, globally, 90% of the SPECT in US tends to use technetium and gated, in fact. So can someone summarize for me what is SPECT in nuclear medicine? SPECT, single photon emission computed tomography scan. Okay, so this is what we are going to talk about, the SPECT. And this is something very important thing which we all should be able to understand. So regarding the basic concept, what happens is, whenever we inject something, of course, it will inject in our body. It tends to go around, okay? So it will go everywhere with the blood flow. So the radio tracer, which we try to inject, tends to get distributed, especially in the myocardium. And it is, of course, proportional to the blood flow. Wherever the blood can flow, that radio tracer will also go. And then there is a camera, which tends to capture whatever is coming out from those radio tracers. So for example, it will be able to capture the photons, and which can be converted to digital data, and we can see it as a scintillation event. And so if we are using a parallel hole collimator, so we will be able to even localize what is the better source of that photon as well. And that is where we try to use a photo multiplier tube, which can show the conversion of signals, okay? And of course, in the end, we can see the final result, which is like a final multiple tomograms of the radio tracer distribution. And on the basis of that, of course, not just we can localize where is the basic problem, but we can also have an overall summary. So as we can see clearly in this diagram, where we are trying to see a cross-section of thorax and myocardium using the different components, and using the different detectors, collimators, which will be able to help where is the possible source of photon emission and how do we capture. So if we try to really look on the practical grounds, this is how it looks like. So if we can see in this, I'm sure now a lot of students can correlate to this massive machine which is there in some of the centers as well. So the image is again displayed in various axes as well. So like the short axis images. The short axis image is perpendicular to long axis of the heart and can be displayed from apex to the base. And then is the vertical long axis. So vertical long axis is the one which is parallel to long axis of the heart and is parallel to the, of course, the long axis, okay? And then comes the horizontal long axis. So this is the third view. First was short axis, then comes the vertical long axis, and then comes the horizontal long axis, okay? So horizontal long axis is again parallel to the long axis of the heart, but is perpendicular to the VLA size. So if one will try to recall, so what these are the three different views. I'm sure everyone can correlate to the these images which we keep on coming across some of those perfusion scans, and we have to correlate to these images, especially on a clinical basis. So as I already said it, various types of perfusion tracers are used, like the Thallium 201, or even the Technetium 99M, which I said it, which is the most commonly one. So for example, for MyoView, we tend to use this tetraphosphine. Otherwise, for Cardiolite, the Sestamib is used, or the dual isotope, which is being used is like the thallium injected, which is mostly injected for the resting images. Otherwise, Technetium 99M, which is injected at the peak stress. Now let's try to understand what is so unique about the Thallium 201. So Thallium 201 is it is like a cation. Can someone recall what was cation, what was anion? Cations are the positively charged ions, okay? Anions are the negatively charged ions. So thallium is positively charged, and it's pretty much, its properties are pretty much similar to potassium. It has a very long half-life, almost I would say like nearly 73 hours, and it does emit 80 kV photons. It's half, and 85% first pass extraction is there. And peak myocardial concentration is seen in 5 minutes, and there is rapid clearance from the intravascular compartment. And the redistribution of thallium begins in 10 to 15 minutes after, related to the concentration gradient of thallium between the myocyte and the blood. And due to the differential washout, the clearance is more rapid than the normal myocardium. And that's why hyperinsulinemic states tend to reduce the blood concentration and the slow distribution. And that's why what we have to advise to the patients, we must advise to the patients is fasting. So the patient has to be there in the fasting state. So that is why this is how it looks like. So as I was telling you, there's a two phases. So what is the initial uptake? And then comes the redistribution phase. And on the basis of redistribution phase, what will be happening is there will be differential washout. Differential washout means, so whenever that heart is getting exposed to the stress, so there will be difference the way in which they are getting washed out of the different areas. So for example, if an area is under stress and is under ischemia, or if it has been infarcted, myocardial infarction has been there, so the washout is going to be different. And that is why when we try to see the redistribution image, so for example, at interval of like 3 to 4 hours, of course, it is going to be very much different. So that is why, for example, there are various thallium protocols like the stress protocol, in which it is injected at the peak stress. And then the images are taken at peak stress, then at 4 hours, and again at 24 hours. And then if we are able to see a component like a reversal of a thallium defect, then of course it tends to show that there is a reversible ischemia. However, something is called as a rest protocol. So as I said, stress protocol is there, then there's rest protocol as well. So rest protocol, what happens is the thallium defect reversibility from the initial rest images to delayed redistribution images. So which I showed you, know, the redistribution image to tends to, of course, show viable myocardium with resting hypoperfusion. And sometimes what will happen is, of course, the initial defect persists. If it is going to persist, it is called as irreversible defect. So that's why some of the things what we saw was, one is a irreversible defect. So initial defect which was there continues to stay. However, we can also label if there is reversible of the thallium defect, then yes, it is reversible ischemia. And yeah, if there is reversibility from the delayed redistribution image, so it is going to be a viable myocardium. So that is why we try to normally use a stress redistribution or reinjection method, which we commonly use. However, if reinjection is there and the fixed defects can also be seen at 4 hours. So timing of the stress image is also important, sometimes which can be early, otherwise the rest distribution image for the resting ischemia or viability. So there are various protocols I would like to share. So as you can see it over here, so these are the various protocols which is commonly followed. Okay. So for example, as I was telling you, the stress or redistribution reinjection, then comes the stress reinjection or the late redistribution, or the rate or redistribution using the thallium 201. Now, what about the other tracers? So as I said, one of the most common ones is called as technetium 99M labeled tracers. So its half-life is pretty short. Okay, 60% extraction is seen. And in fact, uptake is by passive distribution by gradient, and there's minimal redistribution. So it does require 2 separate injections. So one should be at the rest and one should be at the peak stress. And the best thing is, yes, it can be done all in a single day, in fact. And the first injected dose is pretty low, and the 2-day study is like pretty higher dose injected both rest and stress optimize the myocardial count rate, and especially in the large body habitus. And one of the things which we all should remember, especially about the cell cytology, is that technetium 99M tracers are normally bound by the mitochondria. Okay, so that is why the imaging can start later and can be repeated as well. So even with this, so there are various protocols which needs to be followed. For example, this one. So as we had already said it about the 2-day, same-day rest stress sequence can be done. Otherwise, same-day stress rest sequence can be done. Otherwise, the last one which showed about is the technetium system EV or tetraphosphine protocols using the nitroglycerin, which you can see it over here. Okay. So most of us, I think a lot of people may prefer is for single day imaging. However, 2-day image protocol can be better for the image quality. And in fact, most common, the same day low dose rest or high dose stress, their disadvantage is reduction in the stress defect contrast. So what is going to happen is the viability assessment is improved by NTG, which is prior to the rest study. And the dual, there's also something called as the dual isotope protocol. So what happens is the Anger camera can collect image in different energy windows, okay? And the thallium at rest followed by a technetium 99M tracer at peak stress. And if there's rest perfusion defect, redistribution imaging taken either 4 hours prior or 24 hours after the technetium-99 injection. So to summarize, if we'll try to have a look, so this is how it looks like, okay? But yes, we must do the gating as well. So to summarize, to differentiate, this is the table which we all can understand. So about the thallus chloride and the technetium sestamibi, both are, yes, cations, but the one chloride one is hydrophilic. It is pretty long one, okay? The half-life is pretty long. And yes, extraction fraction is pretty high, like almost 85%. And it tends to redistribute. However, in the system, maybe, if we can see it, this is more of a fixed. And so as I had already summarized you about the thallium-201 is the one which is tends to emit predominantly mercury X-rays, which is relatively low energy, which does cause problems of attenuation. But again, thallium-201 tends to have a very long life. And that's why the cyclotron, must be ordered in advance, in fact. And the uptake proportion to regional myocardial blood flow is there, which can redistribute in myocardium. And the stress images must begin immediately following the stress, which tends to enable the delayed redistribution images without a second injection. And the standard dosage is 80 MBQ. And yeah, if a reinjection has been used, so it can be like 120 MBQ. And the effective dose equivalent is 14 millisieverts, okay? And using the re-injection, it goes up to 21. So some of the other components is which is being used also is like the sestamibi and also the tetraphosphamine. And so what happens is they are pretty, the energy which comes out is pretty ideal if we are having a gamma camera. Yes, the good thing is very short half-life, just like 6 hours. So that's why you can even give a really high dosage. And the uptake is again as similar to our concept itself, like, so it is pretty proportional to the regional myocardial blood flow. And again, the standard dosage is around 1000 MBQ, in fact. Okay, and so there are various stress protocols which is being used. So what are they? So what happens is, being clinicians, we all should be understanding what is its indication, first of all. Okay, so regarding its indication, the thing is, we all understand that yes, so one should be fit enough to be able to do the treadmill test, especially using the Bruce protocol. And if there's again contraindication for doing the Bruce protocol, yes, it again becomes like a contraindication, isn't it? And patients should be fit enough to be able to exercise up to the 85% of the maximum predicted heart rate, isn't it? So for example, someone is having an arthritis problem, someone is not able to walk pretty fast. If someone is having a breathing problem as well, when someone tries to walk faster, these are all contraindications. And that is why dynamic exercise is the recommended stress method for patients with suspected or anomalous coronary arteries. So for example, if someone is having a myocardial bridging or microvascular disease, so then it might not be something really good. Regarding the contraindications, so as I already said it, if someone is having mental impairment or even a bundle branch block, atrial fibrillation, someone is having a pacemaker, heart failure, DVT, or even acute myocardial infarction or chest pain as well, it is better to avoid it, okay? And again, if there is a patient, which I said it, if someone is suitable for adenosine injection, or otherwise if someone is adenosine hypersensitive, then we should not again use this. Someone is like having an asthma, or someone is having a heart block, for example, more than first degree heart block, or hypotension, or so for someone for which dipyridamole has already been used in the last 24 hours, or even xanthine has been used in the 12 hours. So if the patient is able to exercise on the is capable of exercise at the submaximal level, then a combined adenosine or treadmill protocol can be used for such kind of patients, isn't it? And then again, we should be able to know that if all the patients are unable to perform a treadmill exercise test, we should try to avoid such exercise. And if we are using dipyridamole infusion for 4-minute isotope injection, 3 minutes after the infusion, isn't it? And the adenosine infusion for 6-minute isotope is normally given 3 minutes into the infusion. So now the important thing comes is the interpretation and the reporting. So the myocardium is divided into 17 segments on the basis of 3 short axes and a long axis slice, okay? And the perfusion is graded from 0, which is normal perfusion, to 4, which can be considered like a no uptake. So something is called as SSS, SRS, and SDS. So what is this thing? So if we can see it over here, is triple S's summed stress score, or which is the stress perfusion abnormality. And the SRS is the one summed rest score, which is correlating to the extent of infarction. And SDS is summed as the difference between stress-induced ischemia. And then we try to do the visual analysis of the perfusion spect. So if it is 0, there's normal uptake. If it is 1, there's mildly reduced uptake. And if it is 2, there's moderately reduced uptake. And if it is 3, it is going to be severely reduced uptake. And 4 is the one when there is no uptake. So as we can see in this figure, the various axes, short axis and vertical long axis, we try to divide the areas into different blood vessel segments like the LAD, RCA, or LCX, and then we divide them further. And finally, so this is how it looks like, isn't it? So we can see the different segments, like in the summed stress score, okay? Stress score, rest score, and then what is the difference? So for example, if the stress score is 23 and the rest score is 15, then the difference scores comes as the 8, isn't it? So we try to use is what is the bull's-eye polar plot, which is a 2-dimensional compilation of all 3-dimensional short axis perfusion data. So this is the bull's-eye polar plot. It is more of a 2-dimensional compilation of the all 3-dimensional short axis perfusion data. As we can see it over here in the stress versus the rest, and then comes the reversibility and how is the extent blackout. So if we'll try to have a full detailed report, so as we can see it in the different areas like the anterior and inferior, which we all can correlate to our echocardiographic imaging. So for example, how it goes from the septum to the lateral, then again, inferior to the anterior, and then the different areas like the anterior, inferior, septal, or the lateral side, from the apex to the base, or the different wall segments. So if we have mastered our echocardiographic imaging, it is pretty much helpful in the different modalities as well. So even in this modality as well, as you can see, it is pretty much helpful. And So for example, if we look carefully in this segment, there is reversible ischemia. So where what tends to happen is a defect is going to appear compared to the normal imaging. Similarly, if there's going to be a fixed scar, so it is going to be present during both the stress and also the rest as well. Due to which, and over here, what do we see over here is there we can see sometimes there is no defect. So for example, if there's going to be no defect during the stress and the rest, so it means it's normal. Otherwise, if there's defect during the stress, but during rest, if there's no defect, it means there's ischemia. However, if there's defect during the stress and the rest, it is going to mean this is scar or hibernating. Similarly, we can again localize where is the defect, and similarly, where is the regional wall motion abnormality as well. So we can further try to see for the additional signs, like the lung uptake of thallium, otherwise if there's transient ischemic dilatation of the left ventricle. So about the thallium-201 lung uptake, if there is a higher lung uptake of the thallium following the stress, it is a marker of severe coronary artery disease or even lower perfusion ejection fraction. Similarly, if there's a minimal splanchnic uptake, it tends to happen that early image after the stress lung uptake tends to be more apparent in thallium. And if there is a more liver uptake, yes, the uptake was missed with the technetium, in fact. So what happens is, if there's a stress-induced LV cavity dilatation, so it can happen secondary to the left main proximal LAD or multiple vessel disease, or even the diffuse subendocardial ischemia as well. Regarding the variations, sometimes there can be dropout of the upper septum or the apical thinning, or the lateral wall may appear brighter than the septum, or it can be minimized by review of series of normal volunteers as well. And whenever we are thinking of the technetial artifacts, there can be some breast attenuation which can happen. Sometimes also inferior wall attenuation can happen as well. And even extracardiac tracers can also happen, due to which we should repeat imaging. Otherwise, we should try to give a patient, like better to give them some cold water to drink to help clear the tracer from the visceral organs. So for example, this is how it typically looks like. So as we can see during the stress, the rest, and in the systole and diastolic images. So a lot of times what will happen is there will be patients with bundle branch block. So during the left bundle branch block, we will see isolated reversible perfusion defect of the septum, which will be revealing heterogeneity of the flow between LAD and left circumflex due to delayed septal relaxation. And there will be the reduced oxygen demand due to late septal contraction. And when wall stress is going to be less, it will be indicated of the left bundle branch block. Hypertrophic cardiomyopathy can be seen due to ASH phenomenon. ASH phenomenon, can anyone recall it for me? ASH. What is ASH, which we see it on an echo? Diagnostic of hypertrophic cardiomyopathy, HCM. On echo, come on, in echo sessions, we learned about it.
Asymmetrical septal hypertrophy.
Wonderful. I'm so happy. At least few people remember the basics as well. So this is the thing. So it should be kept in mind. Asymmetrical septal hypertrophy. And again, it's asymmetrical hypertrophy, otherwise lateral perfusion defects as well. If we see, it can be associated with this. So we should try to use it according to the clinical information which we have. And there is something called as gated SPECT as well. Gated SPECT, what happens is simultaneous assessment of the LV function and perfusion is done, and each RR interval is divided into pre-specified number of frames. Frame 1 tends to represent the end diastole, middle frame tends to represent the end systole, and an average of several hundred beats of a particular cycle length is acquired over 8 to 15 minutes. And normal regional systolic function tends to brighten the wall during the systole. And quantitative analysis of the LV function, so the three-dimensional display tends to represent the global LV function created by information from all the tomographic slices in terms of ejection fraction and also the LV volume. So as we can see in this diagram, so what happens is there are systole, diastole during the different phases, and how do they appear differently as well. So again, over here. So these images are literally the visual representations of what is the pathology of the actual clinical condition which the patient is suffering from. And this should be kept in mind for us to be able to understand what is the real clinical problem of the patient. And that's why we have to sometimes expose the patient to various studies like the MUGA scanning. MUGA scanning stands for what? Can someone summarize for me? Multiple uptake gated acquisition. Okay, so that is what is the radionuclide ventriculography. So in which we try to do the multiple gated acquisition using the technetium-99m or albumin. And then on an average cardiac cycle, the image is reconstructed like 16 to 32 frames per cycle, and the image is acquired in different projections like the anterior, LAO, left lateral projections. And then we try to see on the size of the chamber, regional wall motion abnormality, LV function, or even the time activities as well. So this is how the images typically look like, as we can see it over here. And then if you try to further keep on having a look on the different segments, the anterior, LAO, LAO is for left anterior oblique. And we should time it with the ECG as well, as we can see it over here, isn't it? So if we are trying to think, especially, for example, for the right-sided chambers or lungs, so we should try to use a RAO projection, right anterior oblique, in fact. Okay. So then comes the PET. So a lot of times we keep on coming across, what is PET? So PET stands for positron emission tomography. And radio tracers are labeled with a positron. Okay. So initially what we were talking was they were photon emitting isotopes, right? So, but this is positron. So this is the electron with positive charge. And then the tracers which is used is rubidium-82 and N13 ammonia. And there can be some metabolic tracers as well, F18 FDG, okay? If you all can remember or recall, these are those glucose variations, and the beta decay is measured for the positron emission. So if you'll try to look, so this is how the image looks like. So the patient is there, then there's detector, and so what happens is those, as I said it, the PET scanner is going to detect the opposing photons in coincidence, and that is where the spatial and temporal resolution is going to happen. And the annihilation tends to collide with electrons, which tends to give two gamma rays of 511 keV traveling in the opposite direction. And then comes the perfusion tracer. Perfusion tracers, what happens is there will be diffusible tracers, okay, where they will accumulate and wash out, and non-diffusible, where the rubidium-82 and N13 ammonia is going to be used. Okay, like every imaging modality, this also tends to have some advantages, like the higher spatial resolution, the attenuation correction is pretty improved, and the quantification of the regional wall motion abnormality is pretty nice. So for example, what happens is if you're going to use SPECT, it may be fail to detect the balance ischemia, especially in a multivessel coronary artery disease. Okay, and there can be lower blood flow reserved by the PET. That's why the PET can uh, easily help us for early identification of the coronary artery disease. And yes, it is pretty, has a very high sensitivity and also a specificity for detection of the coronary artery disease. However, it does have some limitation like the high cost. Otherwise, there can be requirement for of cyclotron and short half-life. So that is why it can also be, it is mostly can be used like a pharmacological stress only. So now what happens is there are something is called as the metabolic tracers. So what are they? They're not so oftenly used, but some agents like the C11 palmitate uh, or these F18 FDG, okay, are used for the PET, otherwise the other myocardium imaging modalities as well. FDG, the good thing is like its uptake is an area with reduced blood flow at rest as well, and that's why if it is going to be there, it is going to mark the hibernation. And FDG studies, which is performed after like 50 to 75 glucose loading, like 1 to 2 hours prior to the injection, and that's why the image quality is going to be much better for such modalities. And the enhanced FDG uptake is relative to the blood flow, which is referred to as the PET mismatch pattern. So, which is indicative of the viable myocardium. So, if we look over here, so this is initial one, it shows about the normal function. However, in the advanced stage, it goes into regional wall motion abnormality. Then it can be persistent, and later on, it may return to the normal function. If it is going to happen, this is what is uh, characteristic of stunned myocardium. And it is very much important to understand this concept. And why is that? Because if you're planning to do a intervention, so if there's a hibernating myocardium, if there is a reversible ischemia, then we can think of an intervention. We should think of doing a stenting. We can think of doing a bypass surgery graft to those segments. However, it is already infarcted. There is no reversible ischemia. Then what is the use? Even if you have stented a patient, so that is the time you will notice that, oh, even after stenting, you didn't see good results. What was the reason? This was the reason. So that's why we should be able to understand, as we can see clearly over here is the hibernating myocardium, and then we should also know about the stunned myocardium. On the basis of abnormal blood flow due to the progressive atherosclerotic narrowing, which we can again see it over here. So that is where comes the role of viability PET study. It is the gold standard, okay, using the glucose imaging, metabolic image, and also the cellular membrane integrity as well. So what happens is we try to look for the mismatch. And if we can see, so this is how it is done on the parameters of normal. Is it normal? Is there stunning? Is there hibernation? Or is there any scar? So if we try to look about the images, there's a clear difference, okay, of the myocardial blood flow and the glucose utilization in a normal heart, okay, However, if you try to use the F-labeled 2-deoxyglucose images, if the patient is having a coronary artery disease, again, it is quite a lot different. However, similarly, if we try to look carefully in this image, we will be able to notice the heterogeneous distribution of blood flow, which is preserved best in the anterior septum, okay? Unlike the septum in the patient, which we already showed in the figure 2 earlier, the FTG uptake is different in the distribution of the N-labeled ammonia. And yes, it is increased relative to the blood flow in the anterior, anterolateral, and the lateral wall of the left ventricle. So let me try to show you some more images to make the findings more clear. So over here, what is happening is the blood flow in the lateral wall is markedly increased, which is again consistent with a subtotal occlusion of the left circumflex coronary artery. Okay. So in the guidelines as well, they have been accepting the role of the nuclear cardiology, especially in the acute syndromes. If there's a patient presenting to the emergency department with a chest pain or diagnosis of acute myocardial infarction, or if you're trying to do the risk assessment, or doing the prognosis of acute myocardial infarction, or even the unstable angina patients as well. So over here, when we try to see for the recommendation, so what happens is if we are trying to assess for a patient with a possible acute coronary syndrome, the rest myocardial perfusion intake test is like a class 1 indication. Similarly, to diagnose a coronary artery disease in a possible acute coronary syndrome with a patient is having a chest pain, but ECG is non-diagnostic or negative serum markers are there as well. So we can do a same-day rest or stress perfusion imaging. And again, this is a class 1 indication. So similarly, so for all the patients to see for the LV function, detect the inducible ischemia, or even to see for the infarct size and residual viable myocardium as well. These are all class 1 indications. And even to see for the RV functions, yes, it is like a class 2A indication, but we should be able to know what are the class 1 indications. So as I said it already, if we are trying to see the inducible ischemia in the culprit lesion, otherwise, if we are trying to see for the severity or extent of inducible ischemia in patients where this angina is satisfactorily stabilized, otherwise for identification of hemodynamic significance of coronary stenosis after the angiography, otherwise for measurement of the baseline LV function as well, it is very important. So not just in acute conditions, so even in chronic conditions as well, there are several indications. So for example, to identify the location, the severity of ischemia, if we don't have a baseline ECG, okay? So there are some significant STT changes, but we don't have a baseline change or baseline ECG of the patient, then we can use this. Similarly, adenosine SPECT can be used for LBB patient. Otherwise, if you want to see, there's intermediate coronary lesions. Intermediate, so for example, 50 to 60% lesion is there, but we are feeling confused, like, shall we stent or not? So to see for the functional significance, we can do as well. There are several 2A, 2B indications as well in terms of like a few years after the revascularization for asymptomatic patients, we can try to even see as well. And the PET for the immediate likelihood, SPECT should be used, and it is very much advocated as well, and it is very important. So that's something which we all should not forget. Again, for the initial assessment of the LV or RV function at rest, or the assessment of myocardial viability is very important as well. And again, over here as well, if you are trying to see for the stress or redistribution or the re-injection, or even for the rest or redistribution imaging as well, it can be very important. And if you're trying to serially, on a serial basis, if you're trying to monitor class 1 indications, see class 2A or even 2B, even if you forget, it's pretty fine. But class 1 indications, we all should keep it in mind as well. And even for the risk stratification, it is very much used. So we can risk stratify about the normal perfusion imagings even after adequate rest, okay? There can be sometimes associated with small fixed defect with normal global LV function, which can indicate a good prognosis. However, some patients can be having high risk. So like an reversible defect, which can be associated for more than one territory. And indeed, we all are